This is a presentation on the Georgia EMS data requirements. This presentation was recorded live originally on Friday, June 12th, 2020, and re-recorded for people to watch afterwards. This is actually two parts. This is going to be part one on this recording, but the agenda for part one includes everything you see here. So we're going to talk about or give a review of the Georgia OEMS data submission requirements. We're going to talk about different data elements, including the incident number, response number, PCR number. We're going to talk about how to properly record a medic license number in the state of Georgia, and the Georgia vehicle identification number for vehicles. We're also going to talk about the documentation requirements for the new travel questions and cardiac arrest documentation. And then we will briefly discuss the schedule and a summary of the new Georgia Schematron that was released recently. And then any questions can be emailed to us afterwards. Part two, which is focused primarily on EMS agencies, will have an extension of part one, but it will also include coverage of what the NEMSIS data dictionary is, the extended data definitions, especially for specific elements that have been problematic in the past. And then we will go into details of the new Georgia Schematron. We will talk about EMS performance measures and how to define them and use them. We will talk about a data management policy, what it is and what must it include. And then we'll talk about also how to ensure that you are compliant or agencies are compliant with data submissions to GEMSIS Elite. We will also talk about the GEMSIS Elite Pilot PCR that we've released that hopefully will help you in case you need to update yours to include all of the new elements. And then we'll talk about the focus on systems of care as we move forward with all of our data. So as mentioned earlier, this is part one. This part is considered primarily for EMS agencies and software vendors. So this is just going to be a review. This is not new, but the way we're presenting it is new. So just kind of keep that in mind, is that these requirements have already been there. We're just kind of spelling them out a little bit more because there seems to have been some confusion about the data reporting requirements. So basically, who is required to submit data to the Georgia Office of EMS? Well, EMS agencies that are licensed in Georgia. Now we want to clarify that though, because we have agencies that are licensed in Georgia only, and then we have agencies that are licensed in Georgia and in another state. So for an EMS agency that is licensed in Georgia only, each of those agencies are required to submit EMS data and the run reports for every response that they go on, regardless of where the call starts or ends. So if they pick up a call in Georgia and they transport that patient to Alabama, or they pick up a patient in Alabama and transport them back to Georgia, okay? Because they're licensed only in Georgia, they have to report to Georgia, okay? And it has to be within 24 hours of call completion. For those EMS agencies that are dual licensed, so let's say they're licensed both in Alabama and in Georgia, any responses from an originator or requester from a Georgia entity, whether that's a Georgia 911 system, a Georgia hospital, Georgia nursing home or long-term care facility, etc., that data, regardless of where the call ends up, so even if that patient gets transported to Alabama, because it originated in Georgia, it must be reported to Georgia within 24 hours of call completion, again, regardless of the destination of the patient, okay? If a call originates in another state, or a response originates in another state, whether that's from 911 or for anything else, if that call is completed in a vehicle that's licensed in both states, right? So this one vehicle is licensed both in Georgia and in Alabama. If the personnel on the vehicle are licensed only in Georgia, which basically means that that response is only meeting the requirements of Georgia and it's not meeting the requirements of Alabama, then that call needs to be reported to Georgia, okay? If the call is staffed by personnel that are licensed in Alabama as well, then because the vehicle is licensed in Alabama and in Georgia, and the personnel are licensed in Alabama, and the call came from Alabama, report the call to Alabama. You don't need to report that to the state of Georgia, okay? Now, if the call is completed in a vehicle that is licensed only in Georgia, or people that are licensed only in Georgia, then you got to report to Georgia. So basically, if your agency and the vehicle and the personnel are dual licensed, report to the originating state of the call. But if they're not, then you need to report to the state whose requirements you are meeting. But again, if it's originating in Georgia, you must be licensed in Georgia, right? So that's the Georgia to Georgia transports there. So that's something that we want to clarify there for those EMS agencies. Now, if there's an EMS agency that's licensed only in Alabama, well, then that's different. That's not even on this slide. That's not what we're talking about. Okay, but for agencies licensed in Georgia, you do have to meet the requirements of Georgia, which is the requirements of data submission. So let's kind of go over some numbers, though, just to make sure we're all clear on these numbers. For every incident, there has to be a unique eResponse.03, which is the incident number. So this number has to be the same for all vehicles, for all patients, for this incident from the same agency. Okay, so right now we're talking about one agency. Okay. So this is just the definition right here that came from the NMSIS Data Dictionary. This number can be used to associate multiple EMS responses, dispatch information, and other information to the same EMS event or patient. So again, one incident number per incident. Okay. For every vehicle that responds to an incident, there must be a unique eResponse 04, which is the EMS response number. This must be the same for all patients, for this vehicle, for this incident, okay? This is the internal EMS response number, which is unique for each EMS vehicle or unit response to an incident within an EMS agency, okay? For each patient or response, okay? So sometimes you don't have patients, right? It's a standby or it's something else, right? There's no patient on scene, so that's why we say for each patient or response. There must also be a unique eRecord 01, which is the patient care report number. This is the unique number automatically assigned by the EMS agency for each patient care report. This should be a unique number for the EMS agency for all time. So it's generally best to use this as an auto-generated from your software vendor. And if you use GEMSIS Elite, that is what is done, is it is auto-generated. Because what we don't want is if the agency decides to switch software vendors and they were just counting 1, 2, 3, 4, 5 for the patient care report number, we obviously don't want that number to be duplicated later. So it is best to use that as an auto-generated number. Sometimes that could be like a 32-digit random alphanumeric number on there. Okay, so incident, got to have a unique incident number. Every vehicle has to have a response number, and then every patient has to have a patient care report number. So a couple of notes though. Do not put the patient's name in any of those numbers. So what we've noticed is that some of our agencies don't have like an auto-generate on their numbering system. And so what they'll do is inside the incident number or the response number, they will put like 1, 2, 3, 4, Jane Doe or J Doe on there. Well, you can't do that, right? You do not put patient names in there. And the reason I say that is because those are all national elements. The incident number, response number, and PCR number are all national elements, which means that they get sent to NMSIS and are available to the public. So you can't be putting patient names in there because that's a violation of HIPAA. So please do not do that ever. And for those agencies, when we see you doing it, we're going to let you know that that is not an appropriate thing to do. Okay. Another point, if you have a scheduled transport from point A to point B for a patient, and then a second one later in the day for that same patient back from point B to point A, that's 2 incidents. So it's not like a continuation of one incident. You actually have to submit 2 PCRs on that one. So it's 2 incident numbers, 2 response numbers and 2 PCR numbers, because even if it was the same vehicle, it's a different response the second time, the second trip, the second part of that round trip during the day. So those do need to be separated. So let's go over a couple of examples. Okay, so this example number 1, this is what a large portion of our calls are going to be, is one vehicle responds to one patient for a single 911 or other type of call. Okay, so one vehicle, one patient care report. So there's one unique incident response number, there's one unique EMS response number, which can be the same as the incident number. In fact, we've had agencies ask that, well, can those two numbers be the same? And absolutely, those two numbers can absolutely be the same. Okay, again, just don't put the patient's name in there. And then the one, again, unique patient care report number. Okay, so that's one example. Example number 2, this would be for an agency that has both first response capabilities and has ambulance capabilities. And so let's say that there's 2 vehicles from the same agency. So one is the first responder unit, so that's the fire truck on the screen. One is an ambulance, responds to one patient. So maybe the ambulance got there first or the fire truck got there first, right? But there's 2 crews, 2 vehicles that are there for a single patient. Okay, happens a lot, especially like in a cardiac arrest or something. Okay, so there's one incident number that should be shared between the same vehicles for all vehicles that respond to that scene, because it's one incident. Okay, but then each vehicle has its own response number. Okay, each vehicle will then need to complete a patient care report, they'll have the same patient, but obviously if the engine got there first and they worked on the patient and then the ambulance got there, the patient care report that the engine does will be based on their level of involvement and what they did, and they will note at some point that they transferred care over to the ambulance. The ambulance patient care report will include information in there about everything that was done prior to their arrival, and then it will include obviously everything else that they did as far as the patient goes there. Okay, so that's example number 2. Example number 3, 2 vehicles from the same agency, so one engine, one med unit, but let's say there's multiple patients on scene. Okay, and then they say, so, I'm on the ambulance and I look at y'all and say, well, hey, y'all get those 2, we'll get these 2. So these are all refusals. We'll just kind of use that as an example, is all of these patients are, they're not wanting to go to the hospital. Okay, and they understand that and all that stuff. So what we do though, for the numbering, one incident number, one response number for each vehicle, so 2 total response numbers. And then for engine 1 that took patients 1 and 2, there's one unique patient care report for each patient, so 2 total. And then for the med unit, same thing for patients 3 and 4. So there's a total of 1 incident number, 2 response numbers, and then 4 patient care report numbers. So when we look at this, the engine has 2 PCRs, one for each of their patients that they saw, and then the ambulance has 2 PCRs, one for each of the patients that they saw. Okay, and obviously there's other situations like this that maybe one of them got transported or 2 of them got transported, right? So you can kind of see that the PCR has to reflect what your vehicle did with that patient, or even if there was no patients, right? You still have to record what that crew and what that vehicle did. Example number 4. So we're going to use the same situation as the previous one, except in this case, the med unit looks at the engine and says, y'all can go back in service. We got this one. We'll go ahead and handle all the refusals. Okay, that's fine. You still have one incident number that you both share, both vehicles. You still have 2 unique response numbers, one for the engine, one for the med unit. For the engine, though, the one that got canceled on scene, they still have to do a patient care report. Even though they didn't touch a patient, it's still a patient care report where they have to record their level of involvement with that patient. Okay. And so what they'll do, they might have an incident patient disposition of canceled on scene or canceled prior to a route, prior to arrival. And those are all fine. And then the med unit has to do 4 PCRs. Now, I don't think that's the most efficient use of resources for one unit to do 4 PCRs. However, this is what it would look like: is the ambulance would do 1 PCR for each patient, but then the engine would actually still do a PCR. So in this case, when you're not splitting, the engine still has to do a PCR. They don't get out of documenting that they participated at some point in a response. So now you have 5 PCRs instead of 4. So again, to me, this is not the most efficient, but we understand this happens, and this is how you have to do that, though, is the med unit does all 4 of the patients while the engine does PCR, but theirs would reflect their level of involvement, either canceled, prior to arrival or canceled on scene. So then let's do another example. 2 vehicles from different agencies now, okay? So one is an engine, a medical first responder unit, and one is a med unit from a service that these are 2 different agencies. Okay, and this would apply as well if this was 2 different ambulance services responding to a call and such like that. But when you have different agencies, you're going to have different incident numbers, because that incident number is usually auto-generated by that agency's software. So each of the incident numbers will be different. They still have to have one. So the way it would work out here is for the engine, they would have an incident number and a response number. And then if they took 2 of the patients, they would have 2 different patient care report numbers. The med unit would have an incident number, which is different than the incident number for the engine. They would have a response number because they're vehicle, and then they would have 2 patient care report numbers for patients 3 and 4. So this is what it would look like. So still the same number of PCRs as in the example a couple of ones ago, but in this case, 2 of them are from one agency and 2 of them are for another agency. Okay, so that's kind of how that would work. Okay, another example, you've got 2 vehicles from different agencies, and the ambulance gets there first. So we'll say this one is 1 patient, okay? But the ambulance gets there first, and then they cancel the engine before they get to the scene. So they call and say, hey guys, we got this. And that's fine. So what occurs though is the ambulance has 1 incident number, 1 response number, and 1 patient care report number. Okay. And then the medical first responder unit, the engine, has 1 incident number, 1 response number, and 1 patient care report number. And what they would say in this circumstance that we said that they were canceled before they got to the scene is they would record an incident patient disposition of canceled prior to arrival at scene. And so here's that example is, again, the ambulance would take care of the patient and they do a 1 patient care report. The engine has to submit a patient care report based on their cancellation. Okay. Example 7. 1 vehicle from an agency is dispatched to a standby at a football game and encounters no patients and does not provide operational support. Okay. So no patients, no support. This is just we're just sitting there watching the game with you kind of thing, waiting for somebody to possibly have something, happen. So 1 incident number, 1 response number, 1 patient care report number. But in this one, the incident patient disposition is standby, no services or support provided. So this PCR literally should take like a minute to complete for the medics. So there's really no excuse for the medics not to complete this in a timely manner, because they're not having to put patient names, right? They're just recording times and that it was a standby, no services or support provided. And then a brief narrative that says, we were dispatched for a standby at XYZ Stadium, no incidents, period, right? So something very, very minimal on these though, but we still need to see that. We still need to see that data. So those were just some examples, right? There are other, obviously, situations. I literally could not go over, every possible situation in this video. But we wanted y'all to see the types of examples so that you understand kind of what we're looking for and what is required for data submission for the state of Georgia as a condition of licensure, right? Data submission to us is not optional. If an agency wants to have an EMS agency license in the state of Georgia, they must submit the data in a timely manner as we've defined and under these circumstances that we just kind of went over. So the other thing though, and this is kind of a little addition to those circumstances. So let's say there's another example where the engine and the med unit are both dispatched. The med unit is there and the engine literally only comes to help lift the patient. Okay, so that's the only thing that they're doing is lifting the patient. And when they lift the patient, they're not touching the patient, they're just coming into contact with the stretcher, but they're coming within 6 feet of the patient, right? So within their little social distancing circle. So what that crew needs to do from the engine is their PCR, regardless of if they say assist unit or assist agency, whatever, that engine still needs to record the patient's first name, last name, and date of birth. And the reason I say that is because we can't notify that engine of a possible exposure to a patient that has COVID-19 or any other infectious disease if we don't know the name of the patient. Because what we do on a daily basis now is we download all of the cases from those that are reported to the department for patients who have COVID-19, and we compare that to the runs that are submitted. So if the agency doesn't submit to us first name, last name, and date of birth, we have no way to link that patient that they touched or came into contact with the case list. So we're not able to help those medics by letting them know that they were exposed to someone who had COVID-19. So that's very, very important for us to do, is to make sure that those medics do record just that basic demographic information about the patient. Couple of things on patient names though. Do not ever make up a patient name, ever. Don't put in unknown for the first name and female for the last name. I cannot tell you how many times I see that, and that is completely inappropriate. Completely inappropriate, because that you're telling us that that's their name and that's not their name. Okay, if you don't know their name, or if they refuse to tell you their name, then tell us that. Tell us that you don't know their name. So that's what we call a pertinent negative. So instead of typing in a patient name, you type in a pertinent negative of unable to complete. Okay. Or if they refuse to give you their name, and I've had a patient like that. I've had patients say to me, I'm not going to tell you my name. Okay, then don't tell me your name. But don't come up with a fake name. Don't put in Jane and John Doe. Okay, never put in fake names. Use the pertinent negatives in there. And you may only know their first name, or you may only know their last name, and that's fine. So what you would do is you would record the one, and then you would use the pertinent negative for the other. Okay, so please, please, please do not ever record a fake name, because that kind of screws up our data matching in the system. Well, what about babies that haven't been named yet? Well, that obviously does have a little bit of a special consideration there. So if this is where you're transporting a patient from a hospital, a baby from a hospital, remember that you do. What you should do is you should follow the hospital's naming convention. So maybe that's baby boy, Smith, or baby girl Smith, or whatever it is, and that's fine for you to do that. So follow their naming conventions. Otherwise, you can use this kind of naming convention. So let's say Jane Doe has 3 babies. You would name, them in order. So if it's baby boy number 1, baby, boy number 2, baby girl number 3. So even though like that baby girl is the 3rd baby, but the first girl, generally you would name it by the birth order. So you would say baby girl number 3, even though they're not the 3rd girl, they're the 3rd baby if they're having triplets. Hopefully you don't ever have to deliver triplets in the field, but if you do, then that is one naming convention you can use. And always use the last name of the mom, not the last name of the dad, because right, we don't always know that is correct, so we want to make sure to use the last name of the mom. Okay. So the other thing too, though, is if you are delivering a baby in the field and you transport both baby and mom, remember, don't transport baby in mom's arms. That's not appropriate. But 2, you have to do 2 patient care reports, one for the mom and one for the baby, because it's 2 patients, so 2 patient care reports. What about date of birth? What if you don't know the date of birth? Well, we have some validation rules that kind of depend on you having either the date of birth or having age and age units. So that's the thing that you need to do, is that you need to have, if you know the patient's date of birth, then use the patient's date of birth. But if you don't know the patient's date of birth, use one of the pertinent negatives, such as the unable to complete or refused. But in that case, if you don't know the patient's date of birth or they refuse to tell you, then you need to estimate age and age units, right? You got to have both, those age and age units in there. Okay, so again, that's your best approximation, and it's okay if it's not perfect, but it is an approximation. So we want to go over a few definitions that we're going to be using throughout this presentation. And these are some definitions that are surrounding our data and our performance measures and stuff. They kind of define how we address data concerns. It's what's, the timeliness of the data, the accuracy, completeness. And I'm not going to read the definitions to you because you can pause the recording and you can, read those for yourself. But these are things that are very, very important in the overall quality of our data and the usefulness of our data. Because you can have perfect data, but if it comes, too late, then that doesn't really make it very useful. So our data has to be timely. It has to get to us and be able to get to the hospitals and to epidemiology teams in a timely manner. It's got to be accurate, right? It's got to, have very few, hopefully no errors in there. Okay. Accuracy would refer to things like, did you type the patient's date of birth correctly, right? Did you type the patient's first name or last name correctly? Completeness, right? Completeness refers to, did you answer all of the appropriate questions that you needed to? Did you actually have an answer for them and didn't just leave them blank? Uniformity, right? One of the uniformity things that we focus on is the fact that we only accept version 3.4 of the NEMSIS dataset. We no longer accept version 2, and we do not, under any circumstances, accept version 3.3.4. So we only accept, version 3.4 at the time, right? We will eventually move to version 3.5, but right now that's that. So it's a uniform way of having the data stored. Integration, and this, relies too on that, can you type in the patient's first name, last name, and date of birth correctly? Because when we integrate, what we do is we integrate with other data systems that are also based on first name, last name, and date of birth. So we really need those to be recorded correctly so that that data can integrate with others. Okay. Accessibility, right? Are we able to view our data? Are we able to use it, for legitimate uses of our data? Are we actually able to use it there? And then validity is that, does your data truly reflect what you're claiming to measure, right? So, one of those things on validity, and this can go towards accuracy as well, but if you said that the patient was a male and then you said that the patient was pregnant, well, that's not valid data, right? So this is something that we want to focus on, as all of these. But here's the thing, these do not exist independently of the others, okay? Because if you focus just on timeliness, then some of the other things can fall by the wayside, right? If you're bound and determined to get that data to us within 5 minutes, well, you're not going to be very accurate, okay? And it may not be very valid or complete. But if you focus on everything but timeliness, then the data is not very actionable, right? It's not very useful. So we really have to focus on all of these at the same time. So you can't have one at the expense of the others, or 2 or 3 at the expense of 1 or 2 of them, right? It's not helpful unless we focus on all of these at the same time when we're talking about data collection by our medics. So a note on accuracy. Okay, and this goes along with integration and everything else too. But one of the things that software vendors allow their agencies to do is to change the label on a button. So this is just an example, is eResponse.05, right? The type of service requested. So What the medic sees is the description where it says 911 response scene. What the computer sees is just the 2205001, right? Just a code, okay? But what the medic sees again is the description. So if you would like to enhance that description to make it more likely that your medics will choose the correct button, that's fine. So you might change that button to say 911 emergency response to scene or some other kind of variation there. The thing you can't do is change the meaning. So you can change the label, but do not change the definition of that element and that value. Because if you do, and you're not collecting the right things, then, the medic may be thinking that they're clicking on the right button or the right value for a button, but when it comes across to our system, the only thing that another software vendor sends to us is that code. And if that code that was chosen was not correct, then we're going to get wrong data, and that's going to not be very useful for the hospitals, okay, and for the patient in the long term, that continuity of care that they need. So again, do not change the definition of an element's value. You can change the label slightly, but don't change the definition of it. All right, so who needs to fill out the report, right? So we've talked about all this data. Who is the person that actually needs to fill out the report? Well, the medics who run the call need to be the one who fill out the report, the electronic patient care report. If you review our emergency rule, which is going to be renewed as far as the data goes, one of the things that we talk about in there is that the medics have to be the ones to record the call in the electronic patient care report system. Paper PCRs are not acceptable on a routine basis for them to record everything and then give it to somebody else to then go record the electronic portion of it. And the reason we say that is kind of twofold. For one, the validation rules that we build are not only meant to make the data better, but to make the medic better at documentation. So for example, we have a validation rule that says if you're indicating that the patient possibly has a stroke, the rule is going to remind you to do at least 1 blood glucose on the patient. Okay? And so the reason that we want the medic to be the one to fill it out is we need them to see that validation rule, right? We need them to see that because it enhances their clinical skills and reminds them. It's that friendly reminder of, hey, don't forget that based on the clinical information you've given, you need to also do this, okay? So that's why they need to see those rules. The other thing is the most accurate, timely, complete, uniform, and valid data is going to come from the medics who ran the call, right? No one else knows that call better than the medics who were on that call and provided care and provided treatments to those patients. So those need to be the people to actually record that, and they need to record it more timely so that they remember it fresh, right? So if they wait until their next shift, which is 3 days later, they're not going to remember everything on there. They probably don't remember what they ate for lunch that day. So we don't want to force them to try and remember all those multiple patients that they saw that day. So that's why it needs to be in a timely manner. And that's why, again, the medics need to be the ones that are filling out those reports. Couple of things on license numbers. All right, in Georgia, the license numbers for EMS personnel are a single letter followed by a 6-digit left padded with zeros number, right? And those are zeros, not a capital letter O, right? We have a lot of people who will type in a capital letter O, okay? And the only prefixes for EMS personnel in the state of Georgia are E, I, A, C, and P. Now, these are for traditional licenses. The provisional ones and the temporary ones have different numbering systems in there, but for regular licenses, these are the numbers that we have. But again, the provisional ones, the temporary ones will be done at the end of June, okay, and the provisional ones will be done as soon as they transition, which will be before December of 2021. So this is why these are the standard numberings that we have for medics. Okay, it should match their license level too. So if you're putting a P in front of it, then the ECRU 02, which is the license level, should say paramedic. And if the person gets upgraded, so they were an EMT and now they're an advanced EMT, then what gets reported on the PCR needs to be the correct license number, right? Their current correct license number. Keep in mind, this is not their national registry number. Okay, not their national registry number. And a lot of medics, you would be surprised when medics call us and they're having an issue with the license management system or whatever. One of the first questions is, what's your license number? And they literally have to pause and say, hold on, let me go check. And then they'll tell us a number, and it's like, no, that's your national registry number. What's your license number? And they sometimes don't even know their Georgia license number, which is kind of baffling to me, because that's their license, right? That's their license for their job, right? It's not like a driver's license where not everybody knows their driver's license number. This is their healthcare provider license number that they use to get a job, so they really should know that number. We also want to make sure that agencies are documenting the correct vehicle or unit number, okay? And this is an eResponse.13, okay, which is populated from D Vehicle 01. So we do not accept demographic imports into GEMSIS Elite. We do accept, obviously, EMS import, the run imports. But in that system that the agency has, if they have a different software vendor, then they have their own D Vehicle 01 list, and they need to make sure and populate that with the correct number system, right? And so in Georgia, the correct numbering system for VIDs is a 5-digit left padded with zeros number, okay? So like 0, 1, 2, 3, 4. Again, that is not the capital letter O, it is a 0. Timeliness of data, right? And we've talked about this already. Medics must complete the PCR before they go home, okay? They have to complete it before they go home, and they have to have it, the agency has to have it into GEMSIS Elite within 24 hours. So this is a two, right? There are a couple of people responsible for being able to get the timeliness of the data correct, and that's the medics. They have to fill it out before the end of the current work shift, and the agency has to have it set up that within 24 hours of call completion, which is measured from etimes.13, that call has to be submitted to GEMSIS Elite within that time, okay? And again, as we said earlier, timeliness should not be at the expense of quality. And what we've heard some agencies say is that, well, their medics don't fix the validation rules, right? Well, we'll talk about that in a moment. So what about hardware or software failures, right? So your tablet dies or your software's failing. Okay, that's fine. If you're going to have the medic complete a paper PCR, that paper PCR has to be substantially similar to the ePCR so that they're able to record all of the appropriate data, okay? And then once the software failure or hardware failure is corrected, which needs to be as quick as possible, then that agency has to submit that PCR from the, with the data from the medic within 24 hours of the resolution. Any software or hardware failure must be reported to the department within 12 hours of the failure. Okay, and it must be documented. You got to keep a log if that happens. You got to keep a log of that we can inspect. And to notify the department, you need to email both Dipti Patel at the department and your regional EMS director. Right, if there are failed imports, right? So because the software, that you have some validation errors in there, that is, our system is not allowing the import, then those failed imports, they don't reset the clock, okay? And those failed imports have to be corrected and resubmitted, okay, as fast as possible. Validation scores, right? A validation score is a score, it is not a percentage. And the validation score on runs must be 95 or better. And if there is a low score, it's got to be corrected and resubmitted to GEMSIS Elite. Right? Agencies can review those scores either on the incident list or in Report Writer in GEMSIS Elite. So why 24 hours? Well, one of the things would be because of COVID, right? If you're not submitting data to us within days, and I run the report of COVID cases and I try to compare that against the list of EMS runs, then you're not going to get notified of exposures to COVID-19 in a timely manner. Okay. And we're also trying to push it that where Hospital Hub is the primary means of the EMS agency's information getting to the hospital so that the hospital has the full patient care report. Well, if it's not in GEMSIS Elite within 24 hours, it's not in Hospital Hub, okay? Because Hospital Hub is a direct connection to GEMSIS Elite. So you've got to get it in there so that the hospitals have that information, which is necessary for continuity of patient care, okay? And so, gone are the days where it's acceptable or where it was acceptable to say, oh, we'll get it to you within a week or so. No, no, no. Within 24 hours, it's got to be in there. So this is what we've heard from EMS agencies, and I kind of alluded to this earlier. We need more time for QA/QI before it's released to the state. Well, why? What is it? And this kind of led to the second thing of, well, the medics aren't correcting the validation issues, so that delays the submission because we're having to correct it. The medic's not correcting their times, or they're not clicking on this button or that button. Maybe they were only typing in the narrative and they weren't clicking on the buttons. Well, here's the solution to that. The medics need to be the ones to correct those errors. Okay. The medics need to take responsibility for the data that they're submitting. Okay. So let us know, what are those validation issues that you're having issues with? We can help by writing more validation rules to help prevent bad data, right, and save time for your QA/QI staff. Now, we're not going to review the patient care reports individually for you like your QA/QI staff does. That is y'all's responsibility. But if we can write a validation rule that will help your job get easier, please let us know, right? If you have medics that aren't filling out certain things, we need to know that, okay? And so the medics need to be doing that. And then the agency should really require documentation training every year, even if it's an online system, right? They need to require that every year. So, imagine what that return on investment would be for that agency. Because here's just a little bit of math. A small or medium-sized agency that has 5 trucks a day and each of them runs 5 calls a day. For every 1 additional minute those medics spend on proper documentation per call, okay, 1 minute, right? That's about 25 minutes saved. In fact, it's probably more than 25 minutes saved for the QA/QI team trying to fix stuff later. So the medics really, again, have to be the ones to fix validation issues before the call is submitted. So again, let us help you make your data better. I'm a big believer in the plan, do, check, act. So we're going to make small changes, right? And so what we're doing is with this, with this Schematron and with these trainings that we're doing, that we're doing right now that I'm recording, is we're making that step of trying to identify the root cause. Well, maybe the root cause is the medics don't understand the data and how to record it. Okay, well then let's fix that. Okay, let's fix that and then let's implement it and then let's check it. Is this working? Is this making the data better? Is this, causing less work on our QA/QI team, right? That's what we're there for, is to help make your data better, but also to make it a little easier on your QA/QI team so they can do, bigger things with the data, and they can look at the system as a whole and not just trying to fix little small things or even, medium or, large things on single patient care reports. Okay. Right. So they can focus on other things that are, are making clinical improvements for the whole system. Right. So help us, help you, right? Let us know what you need as far as validation rules, and we can help create those. Okay. Another thing that we want to focus on here is facility names. So, there's a hospital in Augusta that has had probably 10 different names over my career. And you would be amazed to see that we still see all 10 of those being listed in our system. And that's just because the agency have never updated their facility list in their system. Now, if you use GEMSIS Elite, it's up to date because we keep it up to date. Okay. And when the hospital's name changes, you should really change the name of that hospital. Don't change the code that's submitted. Okay, but that's there. And we also have things where they'll say, all right, I'm transported into Grady Hospital labor and delivery. So in the name of the hospital, they type in Grady Memorial Hospital labor and delivery. Well, that's not the name of the facility. Okay. The name of the facility is Grady Memorial Hospital. That is the only name that should come across, is what we have put in the state data set. So vendors really need to hear that, is they need to populate the facility list with what the state of Georgia has put into the state data set, right? There is a reason we do that, okay? And then the code is the same as what we put in there. Because the way to indicate that you're going to labor and delivery is to say the name of the hospital is Grady Memorial Hospital, and that's, kind of picks that code as well. And then the destination under eDisposition.22, which is hospital inpatient destination, is hospital labor and delivery, right? So that's the way to record that. Don't record Grady L&D on the hospital name, because that kind of screws our data up. For software vendors and EMS agencies, this is an important piece. All of the submissions to the state of Georgia come across as XML files in the NEMSIS version 3.4 format. Those calls should be submitted to us on a continual basis, not bulk sending. So the agency and the software vendor should never wait for a bunch of calls to build up and then click send. That's not appropriate, because that can bog our system down. The call should be sent as soon as they're complete, right? Immediately, don't wait on that, okay? And files that are sent, so software vendors need to hear this, files that are sent must only contain one ePCR. Do not bulk send them. And I realize that the NEMSIS standard allows bulk sending, but we don't allow that, right? We don't allow bulk sending. And I'll tell you why, is because the software vendors think that's easier on them, but it actually makes it harder on the agencies. Because so let's say they're trying to send 10 calls at once. If one of those calls that are coming across has an error level validation rule, which we have a lot of error level validation rules, then all 10 of the calls fail, right? So the calls have to be submitted singly, right? One single PCR at a time. When data is submitted to us, so agencies ask us, well, I don't have time to do it. I don't have time to make it correct with our QA/QI team. For one, again, why? Why is it not correct the first time, right? That's something, again, that the agency should be harping on the medics to get correct the first time, right? But we have told agencies, if you have to fix something, so let's say you find out the patient's real name later, or you find out their correct date of birth or billing information, or you need to correct the times because the medic forgot to click that they were on scene, or at the correct time. That's fine, as long as those times are validated by your dispatch log in there. But the first submission of data to us should be completely correct as far as all clinical stuff, meaning assessments, meds, vitals, procedures, times, narrative, all of that. If something needs to be corrected, as in name, date of birth, billing information, you got to correct the times, whatever, or updating a validation error, then that can be resubmitted to us. And it's not going to duplicate the data, right? It is going to resend it to us, okay? And that's fine. But again, the first submission, which has to be within 24 hours of call completion, the first submission should be correct on all clinical information. Okay. Again, the only thing that would change would be the demographics and stuff. Okay. But again, the medics need to be submitting the correct data the first time. Speaking of the narrative, because that was mentioned on the previous one, I read a lot of narratives, and sometimes those narratives are good, and sometimes they literally just copy and pasted the same thing between every single narrative that they've ever written in their career, and we can tell that, okay? But a narrative should tell the story of the patient in this situation, okay? It should, give information in the narrative that you're not able to record elsewhere by clicking on a button. Okay, and sometimes it should have that detailed explanation of medical necessity. The quality of the ePCR and the narrative should reflect the quality of patient care. okay? And if you can answer a question, if you are able to answer a question with another data element, answer it there. You can put it in the narrative as well, just make sure they match, okay? But it's hard for us to run good epidemiological data on the narrative when the button, there's a button that you could have had that data recorded, right? So please, please, please record the bulk of the information as far as buttons go. We're on the buttons that are appropriate, and then the narrative kind of supplements that as far as the story of the patient. Okay, and again, don't use a cookie cutter. Don't use a cut and paste, because we've had cases where I noticed, and we knew for a fact that the patient had no legs because they'd been surgically removed, and yet the narrative is sitting there saying that the patient has both legs intact. And that's just obviously not correct. But it was literally just a copy and paste, and we had, read all the other narratives that that crew in that agency basically had written, and they were all the same. All right, so that's just not appropriate, and that's basically, submitting false data to us. The other thing is auto-generated narratives. We know a lot of software vendors allow the narratives to be generated, and that's fine, but keep in mind that generated narrative comes from the buttons that you clicked, which means that that's the only thing it comes from, and it doesn't include the story of why the patient is in this situation that they're in. Okay, so you really need to don't rely on just the auto-generated narrative. Okay. Travel questions. So previously, we had the travel questions of IT exam 070, 071, 2, and 4. Right, and what those questions were recording is, number one, it has the patient traveled outside their community in the last 30 days. And we had a validation rule that was just a warning level validation rule in there. And then when did they leave their community, when did they return to their community, and where did they go? Okay, and the definition of community is based on your medical director's definition of that. Okay, but these questions were ones that Georgia had written back in the Ebola days, and obviously with COVID-19, some of the questioning system has been updated, and so that's why our new travel questions are based on the national custom elements that every software vendor is able to use now. So beginning on September 1st, we want you to transition to these questions, right? So eHistory 901 and 903, so recent travel and recent exposure to infectious diseases. And then if you say yes to recent travel, then you would answer one of the other travel related questions to say, where did you go? Okay. But again, September 1st, you should start using the new questions, so you don't need to use the IT exam 070 again. And software vendors, please hear this. These questions must be shown to the medic, because we noticed that a lot of software vendors were just defaulting the answers for them. You must show these questions to the medic themselves. You cannot answer for them, okay? But just know that this will be an error level on January 1st of 2021. Okay, so the new Georgia Schematron is published. It is on the NEMSIS website along with the new. So not only is the Schematron there, but the Excel file that has the validation rules in a readable format, a plain plain English format, are on there as well as the warning or the error level messages that will appear. So that's there. You just go to the NEMSIS website and you can download it. So here's our change log for the most recent stuff. Obviously, I'm not going to read this to you. This is posted on the NEMSIS website, but we actually added a bunch of rules, and I will be talking about those rules in part 2, the specifics of those rules in part 2. So a validation rule thing that I wanted to go over. So sometimes we have validation rules that look like they're duplicated, and that's because one validation rule ties to the grid and one ties to the element. So for example, we have a validation rule that you have to have a set of vital signs, right? And some of those are heart rate and blood pressure. Well, in most systems, you don't see the blood pressure button until you go into the vital signs grid. And so we want you to see that there's an error, right, or a warning based on the grid. And then when you click into the grid, so like on this screen, if you were to click on add on the vital signs, then you would see which vital signs you need to do. Okay, and so that's kind of why we have sometimes two rules that address the same comparison. It's one of them is for the grouping, right? Right. So the like I said for vital signs, and then the other one is for the specific element. So what do these new rules address that are coming across here in June of 2020? Well, one of them or a couple of them are based on the length of the call. So the only two times that are mandatory are E times 03, which is the unit notified by dispatch, and E times 13, which is the unit back in service time. Those are mandatory. Can't leave them blank. Can't put in no, not applicable. Right? You must have an answer to those two questions on every single patient care report that is submitted anywhere. Okay. Well, we've noticed a couple of errors that have been creeping up is that if the call was run at close to midnight, the crews weren't recording the date appropriately, so it looked like the call had been run for over 24 hours, which we know is not correct. So we've written a warning level rule that says the call shouldn't be over 24 hours and an error level if it's over 36 hours. Okay. We also have some rules that address trauma so that if, we've always had the rule that every patient you had to answer the cardiac arrest question, is it either no or yes prior to arrival or yes after arrival. Well, we've now also added that the possible injury question is a mandatory question, right? You have to answer the possible injury question on every patient now. And if you said yes, possible injury, now you'll have to tell us the mechanism and the cause. Right? We've already talked about the travel questions, the cardiac arrest questions. These are the CARES elements, the out-of-hospital cardiac arrest custom elements that we've written, and those they have been published on the NEMSIS website for over at this point almost 2 years, a little over 2 years, I think. And what those elements do is they allow us to collect all of the other additional cardiac arrest things, and so those are going to be mandatory. They're going to be warning level initially, and then they will switch over to error level next year. Pre-notifications of hospital. So we have some rules that address that about recording. If you did a pre-notification of the hospital, the last known well time is also on there, and last known well time is related to trauma and cardiac and stroke. We've also had agencies ask us to do odometer readings and make those. We've had multiple EMS agencies asking us to mandate odometer readings on patient loaded miles, and so we are mandating that now. And then we've also want to focus on sepsis in that patients who have. So on sepsis patients, we want to make sure and record a temperature. So we have validation rules now that address that. For agencies and vendors who submit directly to CARES with XML, you will be getting more information about that, but what we're working towards is y'all will not submit XML to them directly. You will only submit it to us in the regular GEMSIS Elite submissions, and that's why the agencies that already are collecting CARES need to switch over and collect the custom elements that the state of Georgia has written. In the future, again, we will make the CARES elements mandatory as an error level. When we're first implementing them right now, it's only going to be warning level, but sometime in 2021, we will transition those to error level. And then in the future, we're obviously going to be switching to NEMSIS 3.5. For one, that makes the CARES questions a whole lot easier because that's part of NEMSIS 3.5. But part of the transition to 3.5 is we are telling you now that we will have training on this prior to that because we want to make sure that when we do 3.5 that we have an appropriate level of preparation for that. And so obviously we will work on that once everything with our vendor is finalized on that, and we'll have to update validation rules obviously on that. So if you have any questions following this presentation, you can contact me, David Newton, at the State Office of EMS, or you can contact Dipti Patel, who is our GEMSYS System Administrator. And that concludes this training. If you are an EMS agency or a medic or a student, you probably should go ahead and watch part 2 of this as well.